Hello, everybody. My name is Chris Harding. I'm a urologist from Newcastle in the United Kingdom, and it gives me great pleasure to welcome you to this European School of Urology webinar, which has kindly been sponsored by Medtronic. It's very exciting that over 600 delegates have been registered for this, and it's my great pleasure to introduce two very esteemed speakers. If I could have my first slide, please. The webinar will be on the topic of sacral neuromodulation and overactive bladder syndrome. And we will hear talks from Professor David Castro Diaz, who works out of the University Hospital in Tenerife and is the current Secretary General of the International Continence Society. We will then follow on with some questions from delegates, which you can access via the Q&A portal at the bottom of your screens. And I will then field the questions to the panel, following which we will have Professor Hashim from the world-renowned unit in Bristol delivering a talk, and we will then have some questions to follow that.
Hello, welcome to this webinar. I have no conflict of interest with this presentation. There are several forms of electrical stimulation of the lower urinary tract, but today we are going to focus on sacral neuromodulation, which consists of implanting an electrode through the foraminal sacrum S3, which is connected to a pulse generator in order to modulate abnormal involuntary reflexes of the lower urinary tract. The history of sacral neuromodulation started in the early 80s under the hand of Professor Emil Tanago at the University of California in San Francisco. Since then, a lot of progress and improvement have been done in the field of neuromodulation. In 1994, the sacral neuromodulation obtained the CE mark approval for being used in Europe. Later on, the approval by the FDA for urgency urinary incontinence, and later on fecal incontinence. But what is even more interesting is that there has been a lot of progress in terms of technological improvement of the devices, the electrode, the pulse generator, and even the remote control for the patient. And nowadays, we also have a device which is fully compatible with magnetic resonance, which is a real advantage because the need of MRI has been limiting very much the indication in many patients, such as those with multiple sclerosis. The mechanism of action is not well known. We know that, or we think that it works through both afferent and efferent pathways, reestablishing the appropriate balance between inhibitory and excitatory impulses. But we also know that neuromodulation produces some effect at the level of the upper center. And the mechanism seems to involve modulation of spinal cord reflexes and brain network by peripheral sensory and possibly motor neurons. So indications for sacral neuromodulation include, in regards to the lower urinary tract, urgency urinary incontinence, urgency frequency syndrome, voiding difficulty, meaning that non-obstructive urinary retention, and it has been also approved the indication for fecal incontinence. However, there are some emerging indications for sacral neuromodulation, which means that although have not been approved by the official agencies, in real life practice is used because sometimes it might help patients with bladder pain syndrome. In fact, it's considered fourth-line therapy among most of guidelines for bladder pain interstitial cystitis. Also for neurogenic decrease of operativity only in incomplete lesion, and probably for constipation and irritable bowel syndrome. Contraindication include stress urinary incontinence, lack of response to temporal stimulation, age younger than 16, severe anatomical abnormalities, spinal cord injury, progressive neurological disease, or any health condition which prevent an implant or even pregnancy. The procedure basically consists of two steps or two stages. In the first step, we introduce an electrode through the foramen and sacrum F3, which is connected to an external pulse generator. Initially, we have this TENS, but more recently we use this Verify system, which is connected via Bluetooth to the pulse generator to the remote control. And if the patient express an improvement on symptoms higher than 50%, then we consider the patient as candidate for the implant. When I started neuromodulation in year 1988, 22 years ago, the electrode we had was this one, which has to be implanted with the open surgery. This was a long time ago, but now we fortunately we have a device that allow us to do the whole procedure transcutaneously, but the need of implanting with open implant of the battery in the case that the patient responds. So after the introduction of the time lead electrode by Michele Spinelli in 2002, we have been using this time lead electrode, which has sometimes for anchoring, preventing from displacement. So, and this is one of the big advantage of the time lead electrode, because the number of migration is lower, and consequently the number of responses to the temporal examination is higher. So the responses we expect during the temporal examination or investigation is in order to make sure that we are precisely at foramen and sacrum S3, is the patient should perceive a kind of below in the perineum, and he or she also should have plantar flexion of degree 2 and occasionally some other tool. But what is extremely important at the time of doing the stimulation, the first stage, is to be aware and familiar with the landmark that we are going to use together with the X-ray for better localization of the foramen or sacrum foramen S3. The position of the patient is also important. So once the patient has responded to the therapy, then we consider he or she eligible for the implant of the battery, and we proceed with the battery to implant the battery, which can be fully controlled with the smart programmer for the patient to increase or even reduce the amplitude of the stimuli. The outcome of sacral neuromodulation has been reported is quite good, with more than 70% of patients achieving clear improvement or cure for the three approved indications for the urinary tract: for this urgency incontinence syndrome, for the frequency urgency syndrome, and also for non-obstructive acute urinary retention. Complication rate is rather low, although certainly most of patients would need revision of the device, either for changing the battery because high impedances, but certainly the complication rate is very low. Particularly, I would like to highlight that the infection rate, due to the composition of the material we use for neuromodulation, is also very low. Sacral neuromodulation also provides very good result in the long term, with 82% of patients expressing improvement. In this report, the most common adverse event was undesirable change in stimulation, and some patients had pain at the implant site, but this adverse effect didn't limit the therapy. The same regarding urinary retention. Again, almost 80% of patients will respond to the therapy with a very low complication rate, and the same with even fecal incontinence, which outcome is even better than for lower urinary tract dysfunction. And this is important because when we ask patients, our patient in our clinic, complaining of lower urinary tract symptoms, we ask them about fecal incontinence, we realize that a high percentage of patients, let's say even more than half of patients, might have some kind of fecal incontinence or bowel disorder, which is important to take into account at the time of choosing therapy. Programming of the device is rather easy. The device comes with a setting of 7 different programs. Although we can change this, we can even do bipolar or monopolar stimulation. We always prefer bipolar because the consume of the battery is much higher with monopolar, and then the life of the battery is shorter. The International Continence Society has provided a recommendation for troubleshooting of the device with this algorithm, taking into account whether or not the patient has enough battery length or has a high impedances, and using S-ray and with a proper clinical approach, we can handle most of the patient problem. But sacral neuromodulation has been in continuous evolution. As I mentioned, initially we used this short electrode that has to be implanted openly. Now we use the time lead, but the system has evolved rapidly. Now we have a smaller device, a smarter program, and even a compatible MRI compatible device and electrode, which will allow many more patients to be or to benefit from the therapy. Living with the implant is not difficult. Often the neurostimulator is set to a subsensory threshold, so the patient that do not have the permanent perception of the stimulation. The patient is able to adjust the amplitude of the stimulation with the smart programmer, or to switch off to switch the device off. Typically, 1 or 2 follow-up visits per year are enough. And obviously, we need to take some precautions, as those that we should advise a patient with pacemaker. And the typical age for the interesting therapy patient is between 57 and 70 years old. The advantage of neuromodulation has been proven because it provides long-term results. It allows a holistic approach for various pelvic floor dysfunction, because, as I mentioned, up to 60% of patients in the pelvic floor center may have a combination of bladder and bowel dysfunction. It's a well-established therapy with more than 325,000 implanting all over the world through the last 25 years. And it's a reversible therapy because if the patient doesn't, it can be switched off immediately, or even in cases that in the past we have to remove devices due to the need of MRI. The EAU guidelines advise or suggest or recommend for refractory overactive bladder either botulinum toxin injection or sacral nerve stimulation with a strong, because there is a good level of evidence. However, we need to balance at the time of making the decision. We have to first have the patient taking part of the making decision process, and we have to take into account the advantage and disadvantage of sacral neuromodulation versus on a botulinum a toxin-A injection, because all of them have advantage and disadvantage, and we cannot say that one single therapy will work for every patient. So we need to adapt the therapy to each single patient. So my take-home message is that sacral neuromodulation is a well-established and efficacious therapy. Sacral neuromodulation is effective more than 70% of patients. The complication rate is rather low. Sacral neuromodulation is in continuing evolution. A better knowledge of the mechanism of action, as well as the improvement on the device, will allow to increase the benefit of this therapy, as is the case with the rechargeable and MRI compatible device. Thank you very much for your attention.
Thank you very much, David, for a very thorough overview of the surgical techniques, indications, and results of sacral neuromodulation. We have quite a busy question and answer panel, which I'll open up now to the whole panel, including Professor Hashim. So the first question we've been asked is, how do you assess response to the outcome of a neuromodulation trial, particularly when it has such disparate indications such as overactive bladder on one hand and urinary retention on the other?
Well, that's a very good question, because it's not easy indeed. So particularly in those desperate indications, but we need to use a voiding diary, particularly for those patients with voiding with urgency or urgency incontinence. The number of catheterization is also extremely important for patients with non-obstructive urinary retention. Patients sometimes start to to perceive feeling of voiding, and they reduce the number of catheterization. But of course, we have to follow the post-void residual. But I would say that voiding diet is essential in those patients who can perform it, and also for those with the retention, because we want to be aware of the post-void residual after catheterization, if the patient has gone from 4 or 5 times per day to 1 or 2 at the very beginning. That's the way we do it.
Thank you very much. We're going to move slightly. There's a couple of questions on the topic of PTNS here, which was not covered in your talk, but I'm going to ask you firstly, how effective is SNS when you compare it to PTNS, particularly for patients with bladder pain?
Well, for the problem is that so far we haven't had a permanent or implantable device for PTNS. I'm not sure that it works for bladder pain. There's good evidence suggesting that PTNS works for overactive bladder, but I'm not sure for bladder pain or neurogenic voiding dysfunction. There's not enough experience, because patient has to come back every week at the very beginning, and once the therapy stops, the symptoms come back. So unless we use a permanent device, which the experience is rather limited nowadays.
Okay, and on the same topic of one of the delegates has asked if PTNS may predict the response to sacral neuromodulation. What are your thoughts on that?
Well, that's true that PTNS might be used as a tool to predict response to sacral neuromodulation. That's true, but the best tool we have to predict response to sacral neuromodulation is the temporary test. We evaluate, we put the electrode, we evaluate the response, and if the patient clearly improves, then it means that it's going to respond to the therapy.
Okay, another question's come in regarding neurogenic bladder, and in particular, neurogenic bladder due to spina bifida. Are there any special considerations in those patients?
Well, I'm aware that there are several publications, several reports suggesting efficacy of sacral neuromodulation for a spina bifida patient, but I have no experience. When I have tried, it never worked. So I have experience with in some patients with MS, with multiple sclerosis, or with incomplete lesion, particularly after surgery for disc hernia. But it seems that the neuromodulation may play a role in the management of neurogenic voiding dysfunction.
if there are patients with sacral agenesis, that obviously makes it very difficult for you to correctly implant the electrode. I think that's perhaps another consideration. We'll move on to the next question, which talks about the phenomenon of initial excellent response from sacral neuromodulation, but then as the years go by, perhaps the response diminishes. Is there any possible theory as to why that might happen, despite the fact that the electrodes may be in the correct place?
Well, that might be the reason. Well, that is true, particularly in patients with that we have done, as someone said, in a desperate way to use neuromodulation for bladder pain syndrome. At the very beginning work, but sooner or later, after 1 or 2 years, the effect decreased. Regarding other indications, sometimes happen, but for that, what we can do is to reprogram the device, because sometimes the initial programmation doesn't work, but so, and we played with that, and most of patients are happy. Although in real life practice, patients come once or twice per year. I mean, reprogrammation is not needed so more often than that, at least in my experience.
Okay, and Hashim wanted to come in on that, I think.
Yeah, I think there is a phenomenon called habituation, and it does happen. I don't think we understand why it happens, but the body seems to get used to it. And I agree, it seems to happen more with the patients with bladder pain. After 6 months, they seem to get back to their original problem. But it's a well-recognized phenomenon of habituation, why the body just gets used to it.
Yeah.
Okay.
How do you deal with that?
It's a very difficult one. I think you can try. You have to first look at all the other problems, make sure the lead is in the right place, make sure they can feel it. But there's 2 ways. Either you say, that's it, the therapy has failed, or you try to implant it on the other side, for example, and see if that changes with another test phase. Yeah.
I also have seen that some patients, after falling, may have displacement of the electrode.
Yeah.
Even higher impedances after falling.
Yeah, exactly.
Agree with that. Sometimes maybe on an X-ray you wouldn't see significant migration, but it only has to be very minor. As you know, when you're implanting these electrodes, just a slight change in electrode position can really alter response. Yeah. I'm just going to move on now, and one of a good question that's come through is do you offer sacral neuromodulation to patients with urinary retention and no detrusor function at all on urodynamics?
Well, that's another very good question, because theoretically the best response for neuromodulation is in those patients with Fowler syndrome. But demonstration of Fowler syndrome is not easy, because it has to be done with concentric needles at the level of the sphincter, and that's not easy. So in my environment, what we do, we consider all non-obstructive retention as candidates for neuromodulation, and we check whether or not the patient responds to the stimulation.
And that would also be my own practice. I would agree with that.
Yeah, I agree. I think the only way to find out is to do the test phase.
Yeah,
there is no diagnostic test. So
okay, so a couple of interesting questions just coming through. One of which is, what's the panel's experience of BOTOX after failed sacral neuromodulation?
Well, that's an alternative, of course, when the patient does not respond to the test. That's what the way we do it, and only after a while we would try it again, or even to try bilateral stimulation. But it's the right approach. We offer the patient either neuromodulation or BOTOX, and the patient, depending on the patient wish, we proceed. And if the patient does not respond to neuromodulation, then we go back to BOTOX.
Fully agree. Another question's come through looking at the results of double-sided bilateral stimulation Is that an option if the single-sided test is unsuccessful?
That's an option, but certainly there is no good evidence on that. I have done it. I have done that sometimes with the previously twin device with a double, a bigger pulse generator, interesting, and the twin, which means that they have the two connection for the two different electrodes. I mean, sometimes work, but there is no evidence suggesting that that it works. Maybe Professor Hashim has much experience on that, but I'm not very convinced.
I agree. I don't think there's any evidence of doing bilateral, and we certainly do unilateral, and the papers that have been published on bilateral say that there is no difference.
Okay. One of the questions that's come through a couple of times is, what about the place of sacral neuromodulation in patients who have, say, urge predominant but mixed urinary incontinence? You talked about stress incontinence being a contraindication, and whether or not in the scenario of an urge predominant mixed incontinence you would still offer.
Well, that's a possibility, because we, for mixed incontinence, we should treat first the most important part of incontinence, the part that contribute more, either stress or urgency. And depending on that, we might use neuromodulation, of course, but we have to keep in mind the effort component of incontinence, which I don't think that neuromodulation is going to work for that.
Okay, what about in patients with severe spinal cord injury and a spastic paraparesis with complete sphincter dysfunction? That's one of the questions that's come through.
Well, I don't have experience in that indication. I'm aware that neuromodulation might play a role in spinal cord injury patients, according to the KD severe study, but that's very experimental yet. And the idea I have is that only for those patients with incomplete lesion, I might try neuromodulation. Otherwise, I wouldn't.
Okay, so we're just about out of time for questions there. We'll do one last one. That someone's asked about patients with Hirschsprung's disease and bladder dysfunction. Any experience of that? I have to say I have no experience of that particular combination.
I have no experience either, but maybe it works as neuromodulation works for at the bowel and the lower urinary tract. Maybe it might work, but I have no idea.
No, I think what we've said all along with these specific indications is that the best predictor of whether SNM is going to be a long-term treatment or a viable treatment is an initial test, and it's a very, very safe procedure with low morbidity. So I'm inclined to offer a test phase to most patients who want to undergo that, where there's no specific contraindications. So we're about half an hour in now. I think it's probably a good time for me to hand over the reins to Professor Hashim to deliver the second talk in tonight's webinar.
Thank you very much.
Thank you, Chris. Can you see my slides?
Yes.
Yes, they're visible. Yes, thank you.
Yeah, excellent. Good. Thank you very much for the ESU and EAU for this kind invitation, and for Medtronic for sponsoring. So I will talk about the role of the new systems in sacral neuromodulation and what patients really want. So you've already heard about the indications and the theory behind it, and where we are, but things have changed in the last few months, or the last year, let's say. These are my disclaimers. So this was really the groundbreaking day in sacral neuromodulation, because on the 20th of January, I had the pleasure of implanting the first and the smallest sacral neuromodulation device in the world. And this is not only the smallest one, it's also an MRI compatible one. So now What does this mean? It means that patients have more choice. You can implant it in a more variety of patients, and patients also have a choice to decide whether they have a rechargeable or a recharge-free system. But what are the differences? So what are the choices? So you've got sacral neuromodulation, you've got a rechargeable system now, which is charged every week, for example, and a recharge-free, which is a non-rechargeable system, which is what we had up to last year. Was a non-rechargeable system. But what is available in terms of devices? So you can see here that there are currently 3 devices on the market that for sacral neuromodulation, with the indications that Professor Castro-Diaz has mentioned. You've got the InterStim 2, which is the traditional sacral neuromodulation device. You can see the size of it. It's about 14 cc's, but you can also see the dimensions. It's about 3.5 centimeters by about 4 centimeters. And these last for about 5 to 7 years, depending on how often you use the device and what power you use it at. But what happened is that in January of this year, this system became MRI compatible for full body at 1.5 and 3 Tesla. So what has changed really is the lead that has changed rather than the battery. The battery has always been MRI compatible for full body, but the lead has changed. This is then the smallest sacral neuromodulation device available is 2.8 cc. So it's about the length of it is about 4 centimeters again, but the width is about 1.5 centimeters. And it lasts for 15 years. And then you've got another company doing a rechargeable, which is Axonics, which has double the size of the smallest Medtronic device. Again, for 15 years. The difference is that with the Medtronic device, you can give patients 11 programs, while with the Axonics, you can only give 1 program. And the advantages and disadvantages will come out later in the talk. So the question we have now is, we have 3 options for patients. How do we decide, and what do patients choose? Well, the way we decide is, there are 3 ways of deciding. You could decide as a surgeon, you could decide for the patient. You could give information leaflets to the patient and say, you decide and we'll do exactly what you want. Or you have the 3rd pathway, which is discussion. So which is the pathway we recommend, is that you discuss with the patient the pros and cons of each, discuss the advantages, the disadvantages, when to use it, give the patient the leaflets, and then decide with the patient. So it's a joint surgeon and patient decision-making process. So this is our algorithm that we use for overactive bladder. For refractory overactive bladder, those who have failed conservative and medical therapy. They're offered both BOTOX and sacral neuromodulation at the same time in the clinic. And they read the information leaflet. We discuss the pros and cons in general of both of them, and then they decide which one they want. For the ones that go for the sacral neuromodulation, we then offer them the percutaneous nerve evaluation, which is the basic evaluation. And we do that under local anesthesia with X-ray guidance in our urodynamic suite. So it's done as an outpatient procedure with pure local anesthesia. And we have our own X-rays. Our technicians and clinical scientists deal with the X-rays for the patients. Then after that, the patient is offered either a rechargeable or a recharge-free system. In terms of the recharge-free, we discussed the advantages and disadvantages, and also of the rechargeable. So what the P&E does is actually also gives time for the patients to have tried sacral neuromodulation, and then gives them time to think about which one to use or which one they want to go for. And then if they decide the rechargeable, then we offer them the 2 rechargeable systems that are available on the market. And we show them the devices, we show them the bags they have to carry and all the equipment that goes with it. So the way to test for sacral neuromodulation, and as we said earlier, this is the only diagnostic test really, is to do an evaluation phase. And I said we do the basic evaluation, and if that is successful, then we go and implant the full implant. If it is not successful, then we find out why it's not successful. If it was inconclusive, then we go ahead and do an advanced evaluation test phase with the tined lead. And then if that works, then we go and implant the full implant. If it doesn't work, we obviously take the lead out. So you can see here that this is the basic evaluation kit where you have the Samsung mobile phone and the external stimulator. And then you've got the full implant here with the rechargeable kit. This is the recharging device, which the patient wears on a belt. These are the 2 batteries and the 2 leads and the recharging and communicating device. So the new technologies in terms of the percutaneous nerve evaluation lead. So this is now also MRI compatible. It can be used for 7 days. It's more stretchy and less likely to move out of position. And you can see here when it's implanted, this is all covered and draped at the end, and the patient keeps it for a week in position. So now you can actually see these through X-ray when we do it under local anesthesia. Now, there's always discussion about why do you do basic evaluation, why do you do advanced evaluation, the advantages and disadvantages of each. Well, we find that the basic evaluation works very well for us. It is done as an outpatient procedure under local anesthesia. It's less invasive and less costly, and therefore it doesn't add extra to our operating lists. And especially, as you know, in the current COVID crisis, many centers around the world have canceled their elective cases, and functional urology usually is the first bit to get canceled. The other advantage is that it's easily removed in the physician's office, and you can test both sides if you want, which we don't usually do, but it can happen. The advantage of the advanced evaluation is that you will have the lead in the correct position from the beginning, but you would have to implant the battery in 2 to 4 weeks. Longer than that, there is a higher risk of infection. Now, this is all previous literature to suggest that the success rate seems to be higher with the advanced lead, and that is basically compared to the basic evaluation lead done in the outpatients based on surface anatomy without X-ray guidance. And we looked at our data, which we presented at the ICS about 2 years ago, and we found that the conversion rate from a basic evaluation to a full implant is higher than what is in the literature, and is in the order of about 70 or 75%, because we are using X-rays to implant the P&E lead. Obviously, the disadvantages is that it may be dislodged in that period. Symptoms may recur once you take the lead out, and you may not be able to put the tined lead in the same position as the P&E lead. But again, with the X-rays, you are more likely to see where you've put it. The advanced lead evaluation is more invasive, it is more costly, and it has to be removed in the operating room. So this gives you an idea, and people would have to do it based on their service specifications and their hospital and their facilities. So that's why each individual will do it according to what they have facilities. The other technology is the overdrive battery technology. So I'll talk quickly about that because that's very important. Because one of the advantages of the Medtronic kit is that over time, the battery remains stable. So if you look at, for example, your mobile phones, if you keep on charging and discharging with time, after a few years, the battery does not charge to its capacity. While with the Medtronic overdrive technology, it actually stays stable. And it's the same even if you charge it every week for 30 minutes, which is what the charging time is over several charges. Again, for example, the iPhone, there's talk about doing 1,000 charges on an iPhone, and then it starts to fade away, or it doesn't work as well. But with the overdrive technology, it doesn't. Again, with every charge, the power on the battery stays the same as well, so it doesn't fade away. And again, there's no loss of capacity over time. So these are advantages of the new technology that is in the battery. Then you come to the decision as to which one you want to do. As you said, there are 3 options now. And now we're spending even more time with patients, trying to explain things to them. It is a balance between the surgical surgeon and the patient. The number of clinic visits is important. So if you have a device which has 11 programs on it, it means that the patients can cycle through programs every 2 weeks, and they don't have to come back to clinic every time one of the programs fails to work. Do they do a rechargeable or a non-rechargeable? Well, again, with the rechargeable, it lasts for 15 years, but the non-rechargeable lasts for 5 to 7 years. So you'd have to do 3 revisions on the non-rechargeable. Cost has to be balanced. Again, if you are revising a battery 3 times, then obviously it is more costly. BMI, the body mass index, is important. So in the past, we had difficulty inserting the interstim 2 into patients who have a low BMI, so very slim patients. And therefore now with the small battery, we have an option of giving them the rechargeable or the smaller device. And then in terms of testing, again, you decide whether you have the PNE or the timed lead test. The rechargeable comes with more accessories. So these have to be shown to the patient. They have to be shown how to recharge it. So it's an extra thing for them to do. And you have to, we ask the patients, how do you let your mobile phone discharge? How often do you charge your mobile phone as a question? Because what that does and what it helps us with is that they are committed to charging a device. If a patient is not committed to charging a device, then a non-rechargeable would be better for them. And compliance with recharging is important, because if it stops working after a week or the battery discharges after a week, then it will stop working and the symptoms will come back. Lifestyle is important. What I mean by that is if you have a patient who is traveling every week, I know it's not possible at the moment with the current climate, but in the past, people travel a lot, especially for work, for example, and you have to carry a bag with you with all the recharging devices, and you're only on hand luggage, then you may be limited as to what you can carry with you. It also means that patients who recharge are reminded of their condition, and some patients don't want to be reminded that they have a condition that needs treatment, and they have the battery and therefore go for a non-rechargeable. Dexterity is important. Again, if you are recharging, you have to wear a belt with the recharging device on it. You have to have good manual hand function to locate the device, and therefore hand dexterity is also important. So these are the factors that we think are important for patients, and we discuss them with each patient that comes through in terms of whether they want a rechargeable or a non-rechargeable. So what we've done is we've actually looking at a quality improvement project in terms of decision guide for patients. And so we devised a questionnaire, and on that questionnaire, we ask what is important for the patient. So the criteria that are on the questionnaire include the size of the battery. So we want to see if that is important for them. Whether the size of the remote control is important, because the Axonics remote control is smaller than the Medtronic one. The ease of use of the remote control, whether that is important or not. Do they want rechargeable or non-rechargeable? Is ease of recharging important? Because again, if you wear the belt, they try the different belts and the different devices. Do they want to be recharging every 30 minutes for a week, every week for 30 minutes? Do they want to come back to clinic every now and then, or do they want to have, say, 11 programs or 7 programs on a device and then they work through it? And I've just, a nice tweet came through today saying that Medtronic are offering Zoom on the devices. So that's a new technology as well, where patients can log into Zoom and actually speak to someone about changing programs, for example. The number of revision surgeries, so that goes between rechargeable and non-rechargeable. And finally, the length the company has been on the market. And we've identified that these are the factors that are important to patients, and we're collecting the data at the moment. So hopefully we will have some data to present at the EAU next year. So this is just showing you the devices. This was a patient who had the InterStim 2, the non-rechargeable prior to it being MRI compatible. And you can see it's in the correct location. It's in the S3 foramen. The leads are, the electrodes are in the correct position, and it's curving outwards. So everything is absolutely in the right position. The only problem is this patient had a very strong motor response at S3. Even when we changed all the stimulations and we played around with the programs and everything, she kept on having the big toe kept on flexing whenever we switched the device on. And that gave her pain also at the battery side. So she had the InterStim, the microstim or the InterStim micro. Having taken that one out, we implanted this on the other side. So this is on the left side of the patient, and we've put it into S4 rather than S3. And the patient is now very happy. She's getting on with her life and happy with having the smaller device with less pain and less motor response in the toe. So one of the important questions that I asked myself is, well, how am I going to know if a patient has an MRI compatible device or a non-MRI compatible device? And this is just a table to show some of the differences. So the pre-2020 patient controllers, some of them look like this, and the others look like that. But the defining feature is that the ones who are full body MRI, there is an icon on the phone which says that you can switch the MRI compatibility, and you press that button. So if you look at the patient controller, you'll see that they'll have an MRI icon, and therefore that device is full body MRI compatible. You can look at the leads, obviously at the when the leads were implanted, and you can look at the numbers of the leads, 978B1 and 978A1. Or look at the leads on X-ray. So the MRI compatible leads are thicker, they're more braided, and they're darker on X-ray. The difference between the big one, or the interstim 2, and the microstim is you can see that the electrodes are much closer to each other on the interstim micro. And then finally, if you take an X-ray, as I showed you earlier, you can see that all the interstim micros are MRI compatible, while the interstim 2 are not all MRI compatible, and then you will have to look at the lead and see if it is MRI compatible or not, or you look at the model. So 3058 is the battery, which is the interstim 2. The 3023 is the previous model prior to interstim 2. So in conclusion, the take-home message is that now patients have more choice. You have a rechargeable and a recharge-free device you can offer patients. Depending on the circumstances of the patients, the patient choose which one they want in discussion with them, and then you decide. You can have a much smaller device, so patients who are very slim or who have battery pain, then those can have the interstim micro, so you can offer it to more patients, and it's full body MRI compatible, which means we can offer it to neurogenic patients now, patients who may have MRIs in the future, such as patients who have men with possibility of prostate cancer needing MRIs in the pelvis. So you can offer it to more patient groups. So these are the three main advantages of the new technology in terms of sacral neuromodulation. Thank you very much for your attention.
Thank you, Hashim. Excellent talk. You'll be pleased to hear I've got some rather testing questions come through
Okay.
Q&A portal. So the first one is, if the patient does express an interest for a rechargeable device, are there any factors which play a part in the decision making with regards to one over another? So you mentioned at the start of your talk that there are, of course, a couple of now commercially available rechargeable devices. Do you have any sort of steer as to on what circumstances you would choose one over another?
So in terms of the patients decide whether they want a rechargeable or a non-rechargeable. So we offer both to them. We discuss the advantages, disadvantages. It's very difficult. I mean, we do steer some patients to one or the other. So if we think they are not compliant with recharging, or it will be a big burden on them to say, let's say, carry the bag. So we have to highlight these things during the consultation. Because the natural thing is, this is a new device, it came on, it's very small, everyone wants it. But actually, once you go into the nitty-gritty of discussions and why, why do you want this and so on, that's why we developed the patient decision questions, so that we can have a joint decision and make a choice. Whether we choose one company or the other, again, we offer both of them to the patients. But in general, I think, I mean, the data will show, but so far we've had patients change from the Axonics, because that came out first, to the Medtronic, purely because it's smaller. So having the smallest device is what patients want.
Okay, really good practical question just come through here. How do you explant the electrode? Are there any top tips?
So again, the main top tip is don't pull it where the battery is. So when you put when the device is in, you open where the battery is, you disconnect the battery, and then make another small incision where you inserted the lead, and then from there you pull upwards in a rotational motion, rather than pull very quickly, because you'll snap the lead.
And in the scenario where the lead snaps, what do you do then?
So if it depends which lead snaps. So if the new lead snaps, which hasn't happened so far, it's not a big problem because they're MRI compatible. It's when the old leads snap, which are not MRI compatible, that is a problem. And if you need to take it out, then you'd have to open down to the fascia and find it. If you are not comfortable doing that, then you have to get neurosurgery colleague to come and help you to do that, or a spinal surgeon.
David.
Yeah, I have had that problem twice, and yeah, one was removed, but the other one is right into the sacrum, and it's there forever. So, but I would like to ask Hashim, because it is not clear for me whether or not you do P&E always, or sometimes you go directly with the time lead.
We always do P&E.
Always.
We always do P&E, and then move to a timed lead. If the wire has moved out of position, then we go to a timed lead, but we always do a P&E.
And do you evaluate just motor responses or also sensory responses?
No, we do sensory response, because we're basing it on local anesthesia. So it's pure local anesthesia. If they don't get a sensory response, or we can't get a P&E in, then we would go ahead and do a timed lead at a different date and time in the operating room.
We also do it under local anesthesia, but I thought that in many institutions in the UK was done by general anesthesia.
No, well, I think so, yeah, majority do, but we are probably one of the few ones that do pure local anesthesia for P&E.
Yeah. Sorry, Chris.
Yeah, we're exactly the same. We would try and encourage local anesthetic, but it's always within the operating room. So very occasionally I'll need the anaesthetist to give a bit of sedation. So I think it is quite variable practice around Europe, as you say. There's an interesting question come through from a colleague in Spain talking about access to sacral nerve stimulation, and I thought I would address that. A couple of years ago, in association with some colleagues at University College Hospital in London, we published something looking at access in the UK to sacral nerve stimulation, and only 40% of UK urologists said they had access. So I'll put the question out there. Is there anything we can do to improve or standardize the access to sacral neuromodulation across patients from different backgrounds?
Well, if you allow me to answer that, in Spain, because healthcare system has been transferred to the local government, when any one of us has or needs a therapy for a given patient that is not available in the local environment, we can refer the patient to those referral hospitals. And that's what used to happen with neuromodulation before we started 22 years ago. But I mean, it's available in most of the sites in Spain.
Okay. Another question about, is there any place for, or how do you manage psychological support for these patients?
That's a very, very good question, and you know, it's a functional problem. It's a difficult one, and we sometimes have support from clinical psychologists to help with that. So we would refer them to a clinical psychologist, because that is a very big element of it in some cases, because it's beyond our remits, I think, following doing everything in terms of implanting, providing all the clinical support for the device and so on. I think if there is any clinical psychological elements, then they have to be referred to a specialist in that field.
Okay, we're almost running out of time here. I've got two quite good questions, so if we could keep our answers quite brief. The first one is, if BOTOX fails, how much time would you wait before a trial of SNS? I think that's a really good question, very practical.
Yeah, that's a very. I agree. It's difficult. I normally wait until 6 months, and if all the symptoms recur, then I would do a test phase of SNS. But you could argue and say, well, if it's failed, then the symptoms are there. Why not try it? I just worry that there may be an element of effect, detrusor failure, or let's say underactive bladder caused by the BOTOX, and therefore maybe do a flow test beforehand just to make sure that the symptoms are there.
Okay, and we'll finish off with one final question, which is, when you're going to perform a PNE procedure, have you had any experience, or do you know of any literature which might support the use of ultrasound guidance rather than X-ray? I have to admit, I don't. I've never done that, but I don't know whether colleagues have.
No, I mean, so it's interesting. So we run the sacral neuromodulation course at the EAU, and Dr. Musco from Italy, she does it under ultrasound. So one of the stations is looking at the use of ultrasound. I've never used it, and we always stick with X-ray. But certainly, as PNE can be done under ultrasound, and there are proponents who can do it under ultrasound. But certainly it's not a UK practice or anywhere else, except as far as I know, in Italy, they do it.
Okay, that's great. So I think we'll probably draw things to a close there. There are a few outstanding questions, but I shall type answers to those at the end of the webinar. I just need to say a couple of things. Firstly, thank you to the huge number of participants who've tuned in for this webinar. Secondly, thank you to my two fellow panel members who fielded some really difficult questions and gave excellent talks. And finally, I just must remind delegates that this is actually eligible for a CME point, which will be dependent on you completing a feedback questionnaire and having attended for at least 30 minutes. So unless there's anything that anyone else would like to say to finish off, we will bid you a good night, and thanks once again for listening.